about to determine whether or not her med regimen was appropriate?
Potassium.
I heard potassium, yep.
Serum creatinine.
Serum creatinine, yep. So those look good, right? So meds are safe, check. Cool. So then, can I get somebody in Augusta to tell me about your assessment for this patient's hypertension?
As we already mentioned, she is stage 2 because she's over 140 systolic, and her target would be 130 over 80 for those same guidelines, so she's not at her target.
Great. And so we've identified she's not at her target, and we probably need to do something about that. So what's our plan for this patient? Oh, and I'm sorry, what guidelines did you use for that?
The ACC AHA hypertension guideline.
Perfect, 2017, right? Okay, so what's our plan?
Increase the lisinopril up to 20 milligrams a day.
Okay, and talk to me about how you decided that. Where did you draw that information from?
Isn't it over 20? Like over 20 or 10? Like
I did the same thing, and I did it because she was already on it and it wasn't maxed out.
Okay. What do the guidelines say that we should do for therapy for people with stage 2 hypertension? I'm sorry, you broke up a little bit. Can you say that one more time?
If they have stage 2 hypertension, they should get 2 first-line agents.
Yeah, so if they were medication naive, we'd add 2 new blood pressure agents. So this lady's already on a med. It's a little bit harder to make that call, right? Probably not in real life, I am not going to add 2 new agents on top of it. I am going to increase lisinopril, and because the guidelines recommend adding 2 new agents, you have choices. I feel like you can either increase lisinopril like you did to 20, and then maybe add a diuretic at a low dose, right, as your second agent, or you could be more aggressive with your 1 agent. So for example,
we can't hear you.
We don't hear you in Savannah.
Mic died. She's changing it.
The mic died. She's looking for a battery.
Hey.
okay, I'm back. Everybody hear me? Great. Okay, so what I was saying is, in this instance, what I would probably do in my practice is just bump up to lisinopril 40. But you could also make an argument for going to like lisinopril 20 and adding a diuretic. We want her to be on that ACE inhibitor, right? Why?
ACE inhibitors have like renal protective qualities.
Yeah, so especially because she has diabetes, first line therapy for her is the ACE inhibitor, so that's great. I'm glad she's already on that. And then like thiazide diuretic would be my second choice.
Dr. Stone,
Yes.
I looked up last night that thiazide diuretics cause hypercholesterolemia and can inhibit a patient's glucose control. So would you want to avoid those agents in this patient, considering she has hyperlipidemia? Granted, she hasn't had a lipid panel in a while, and her glucose isn't controlled right now?
No, I would not avoid it in those instances because the effect of change of the thiazide on those parameters is pretty minor, and it's a preferred therapy for hypertension. So I think her need for hypertensive therapy outweighs the clinical significance of those potential interactions. So you'll regularly in clinical practice see people with diabetes on thiazide diuretics. So, you know, it's kind of that triad, right? Everybody has diabetes, hypertension, and hyperlipidemia, and the standard regimen is your ACE inhibitor and your thiazide usually. Okay, so either way, if we start the diuretic or if we just go with the higher lisinopril dose, what kind of follow-up do we need?
I said follow up in 2 to 4 weeks to check blood pressure and potassium and serum creatinine levels.
Awesome.
And also to have patient monitor blood pressure at home.
Yeah, so that overlaps nicely with our diabetes, right? She's coming back for insulin, check-in, and titration, so perfect. That's 2 to 4 weeks. Let's bring her, also check her blood pressure in 2 to 4 weeks. You said serum creatinine and potassium, that's ordered in a metabolic panel, right? So we can order an A1C and a metabolic panel and cover all of those. That sounds like a plan. You want to make sure that you're also talking about, and I didn't mention this in diabetes, but dietary education, both for blood sugar control and for sodium reduction with high blood pressure. Okay, and then let's briefly talk about lipids. So there's no subjective for her lipids unless she tells you something about her meds. Did she say anything specifically about her medication therapy? For statins?
She said that she couldn't afford it.
Okay, she couldn't afford it. And what does that mean is happening?
She's not taking it.
She's not taking it. Perfect. So she's not taking the lipid therapy we think that she's on. Okay, what objective information is available?
There's a lipid panel from September 3rd.
Yeah, so are any of her lipid parameters significantly outside of the normal range? No, she doesn't have an abnormal lipid panel per se, right? But she may still be indicated for lipid therapy based on her risk.
About her labs.
Yes, ma'am.
I got that her triglycerides were 239, and I feel like I remember our goal was to be less than 150, but I know that triglyceride targeted therapy is usually for greater than 500, so is that just not clinically significant?
Yes, so we treat for triglycerides greater than 500. She's a little elevated, but she's not to the point where we would alter treatment yet. You're going to talk about diet. Uncontrolled blood sugars also increase triglycerides, and triglycerides are calculated off, and LDL are calculated together. And then, if you're looking at a lipid panel, the part that's affected by fasting or not fasting are triglycerides. So there's a lot of factors in there. But essentially, what I want you to know is she's not 500. She doesn't require treatment at this point. Okay, so we've got her lipid panel. So this is the tricky part, right? So what's our assessment of this patient's lipids needs? So does she fall into one of the 4 main statin groups?
No.
Albany, what do you guys think? Does she fall into one of the 4 main statin groups?
Yes, because she has diabetes.
How old is she though? And what's that algorithm say?
John,
Augusta would like to say
She's not old enough, so no.
Right, so the quiz question was, does she fall into one of the statin benefit treatment groups, the 4 big ones that are within those guidelines? And no, she does not currently fall into one of those. However, the 2018 ACC-AHA guidelines talk a little bit more about this. So I put this in here because this is tricky. This is a gray area, right? She doesn't fall into our major guidelines-driven care. All those ACC-AHA algorithms are for people who are 40 or older. I get people at Mercy all the time who aren't 40. So what do we do with them? So I just wanted to bring your attention. This is the newest lipid thing out there right now. The, again, ACC-AHA 2018 guideline on blood cholesterol. And again, I don't expect that you guys would know this nuance, but again, we're talking about how to find things and how to assess treatment. So we know she doesn't fit into the major groups. So we're going to go to the guidelines and see what do they say if she doesn't fit into the groups. So she has diabetes, which you've appropriately identified, right? So we know she's at higher risk. She's not secondary prevention, but she is an adult with diabetes, okay? So if you read into these, down here, 0.7, this is new. So before it just said, use clinical judgment, up until these came out recently. Now they say in 29 to 39 years of age, with diabetes that's either long in duration, so greater than 10 years. How long has she had diabetes?
I don't know.
12 is what her chart says, right? Okay. Or if she has end organ damage, so albuminuria, other issues with organ function, it may be reasonable to initiate statin therapy. That's about as defined as we're going to get for this patient population right now, because there aren't many trials with her age bracket in it. Most of the trials are done in people 40 and older. That's why the recommendations say 40 and older. So for this lady, what did we calculate her ASCVD risk to be? There was a group that said earlier it was like 50%. So for this lady who's got high blood pressure, diabetes, PCOS, some other obesity, I personally would feel most comfortable putting her on a statin. And this is the guideline that I would use to reference that decision. So if we are to put her on a statin, what kind of statin do we want to put her on? I think you could do moderate or high intensity, right? She's not specifically carved out for one specific intensity of statin because we've got this pretty vague guideline recommendation here to go on. But for her, I would try and get her started back on a statin. And just as an aside, atorvastatin is now on the Walmart list. This is new, I'm so pumped. $9 a month you can get atorvastatin, so that's pretty exciting. So for this lady, I would resume her statin therapy and I'd try and help her find a way to make it affordable. And then when do we recheck a lipid panel after we start a statin? And then what are we doing that for?
Don't you, is it 6 to 8 weeks?
Yeah, you have to wait a minimum of 4 weeks, right? Then probably 6 to 8 weeks is better, Teresa, I like that. So somewhere between like 4 and 12 weeks, you can check your lipid panel again. Usually we're checking to see if they've had that percent decrease, right? So like if they're indicated for a high intensity statin, we're trying to look to see if their LDL has in fact dropped 50%. But for this lady, she doesn't have a pre-specified end like percentage decrease. So she's a little bit unusual. I would probably recheck a lipid panel one more time just to make sure everything looked good. I'll leave it at that. So I would recheck just to see how much effect she saw from that statin, and then after that she can just switch to annual, right? Annual checks. Okay, so now let's tackle the last thing. This probably is more important. Her PCOS probably is more important than her hypertension and hyperlipidemia, but sometimes it's easier for me to talk about those three in a group because they're so closely related. But her polycystic ovarian syndrome. So how do we know, like what complaints does she have that are related to her PCOS?
Facial hair.
Facial hair, what's that called?